I'm Dr. Carine Hamo from the Circulation COVID team, joined today by Professor Héctor Bueno from the Hospital de Octubre and the National Cardiovascular Research Center. Professor Bueno, thank you so much for being part of our initiative, Circulation COVID Updates from the Front Lines.
You're welcome.
So, as you know, these are extraordinary times as the world grapples with how to fight the rapid spread of this pandemic, and Spain, unfortunately, is one of the countries that's most severely affected. Professor Bueno, please share with us your experience thus far. We'd love to start with particularly from a cardiovascular standpoint. What have you seen at your institution in terms of COVID-19 and cardiovascular complications?
I would say that there's two views. One of the, I would say probably the most striking thing is what we're not seeing. There's been a dramatic drop in the number of patients with acute myocardial infarction, STEMIs. We receive a lot of them. We're not seeing them anymore, very few of them. We're actually like 20–15% of our capacity in cardiology. We don't know where these patients are. Maybe they're scared, they're not coming to hospital. I don't know whether with the close out, the pollution is improving and there's less patients, but that's one thing. The other second thing is actually we're not seeing that many cardiovascular disease related to COVID, not because there is not, because I think there is, and we know and we've seen a few myocarditis. We hear more prolonged QT because actually the drugs which are being used to treat patients with COVID infections may prolong QT, though we haven't seen so many Trusadip 1 or syncope of that. But I will come to these later. Most of these patients are not monitored. We just overflowed. Actually, we haven't seen that much. We've seen a little bit of heart failures, but mostly they're seen on hospitalized patients, and hospitalized patients in this situation are very sick patients, most of them with bilateral pneumonia, severe respiratory insufficiency. In general, it seems that the contribution to the clinical situation is, I would say, marginal.
There have been reports, a lot of different reports about biomarker elevation, particularly troponin, and whether that be from acute MI or myocarditis. Have you been checking biomarkers of myocardial injury at your institution, and how have you been managing that?
We're not managing that. This is not the time for academic medicine. We're in war state. This is the worst thing that I've ever seen, and I think probably most of us will ever see from a health care standpoint. We're completely over flooded. The situation is just catastrophic. We're one of the largest hospitals in Madrid. It's about 1,200 beds. We have now more than 800 COVID positive patients in the hospital. We have, I'm not sure the exact number of ICU beds that we have, but all of them have been put together and extended to different units. We're using now operating rooms for intubated patients, and that's beyond 200% of ICU occupancy. So we've been moved. Cardiology ICU, our ICCU was covered by COVID patients in the first week. We moved to the reanimation unit, the post-op unit. In 3 days, we had to move to the outpatient office. And we're actually in the ambulatory surgical unit, which is considered still a clean, or it was considered a clean unit as compared with the infected people. And that now there's no building, so we have several buildings. There's no building where there's no COVID positive patients. We just overflowed. Yesterday, there was nearly 200 patients in the emergency department. They're coming by hundreds. All Madrid is in this way. We're completely overcrowded. So, I mean, it is just impossible to think in academic medicine. And I think our colleagues around the world need to think that cardiology is marginal here. We're not cardiologists anymore. We are, of course, but now we're doctors. We need to help all the people that are in need, or our colleagues in the ICUs, in the medical wards. We have hundreds and hundreds of people with very severe pneumonias. Many of them just can't get to the ICU because there's no ventilators. So when I still read in the evening when I'm in the mood, because this is really sad, about these discussions about troponins and VMPs and so on. Who cares? People are dying by dozens every day. We cannot help them as we wished. We have no facilities for all of them. Thanks God, the Army has just opened 5,000 bed camp hospital in Madrid. And Madrid is one of the places where the healthcare system gets more than 100 healthcare facilities, 34 public hospitals, more than 10,000 beds, and nearly 600 ICU beds. They ran out in the first week. We're just putting all our efforts in trying to help and save all the people who get infected. So honestly, we're not paying much attention to the, still are running, of course, all the primary PCIs. We get this, but actually we have suspended all elective procedures. We're very restrictive because actually one of the other problems is we're getting healthcare professionals infected. I think in the news it was 12% considered as infected in health professionals just in the first 1 week, 10 days. So this is a big issue. So, I mean, doing echoes is not out of risk. And if it's not going to change the prognosis or the clinical management, we are avoiding to do things that will not change the management of the patient. So we're not doing at all academic medicine. That's the sad story that we are living now here in Madrid.
Professor Bueno, you provide really sobering insight, and I completely agree with you at this time. While we are all inherently want to practice evidence-based and use this experience to learn from that, and of course we will learn a lot from this pandemic. I completely appreciate that. Right now it is just the time to really fight and get through it. You mentioned the high rates of healthcare providers affected in Madrid. How are you coping with that in terms of protective equipment? What are you also, I'm sure, limited in terms of resources? Have you restructured the workforce to sort of account for that?
Yeah, of course. I mean, we have to take measures, but I mean, the numbers, it's so amazing in terms, so there's a shortage of everything. There's no beds, there's no ICU beds, there are no ventilators, but there's becoming a shortage of masks. There's shortage, of course, of high protection material equipment, so it has to be limited. And actually, yes, there's these workflows, and as I mentioned, they try to put the infected people in the same rooms, and then floors, and then buildings, and nothing is enough. We try to keep like clean areas, but actually the situation is so widespread that you have a patient with a STEMI, primary PCI, gets fever a few hours later, starts coughing, and he's COVID positive. And he's in the middle of where we are now, one of these facilities we just were built up in a few days. And then the clean area becomes unclean. We're splitting the teams in smaller groups. We're trying to protect them. We're trying to get people retained at home just to have a turn for that. But it's still, every day we're asked to help people. So we have trainees, cardiology people taking care of full areas of COVID patients, but it's not cardiology. It's just COVID pneumonias. We're taking care. We started actually taking care of the non-infected internal medicine patients, but that took a few days because the demand was so incredible that we had to take. So as a cardiology team, because our work actually has shrunk, we're helping all our colleagues in the ICUs, in the COVID areas, in the emergency departments, and so on. I think now is not the time for academic medicine. It's not the time. Of course, we will have to learn, and we have to learn about what we did and we should have done. But this is the time for generosity. I think this is the time for solidarity. We're cardiologists, but we're doctors overall. And we need to help these people, and we need to help these colleagues. There's several nurses, several fellows, and several staff who are getting sick, and some of them very sick. We have colleagues who have been very sick, and that's a problem. So we have to be very careful with that.
Yes, absolutely. What would your advice be? You know, of course, as we mentioned, Spain is particularly affected, but we can see the trends rising in the U.S. And so the most we can hope is to at least learn from your experience. What would be sort of your advice and guidance as the U.S. gears up to probably face its worst of this pandemic?
Well, first of all, take it very seriously. I mean, and learn from our mistakes. I think probably you're already too late in terms of closing and reducing personal contact, in the general population. The flood is just unbelievable. It's gonna collapse the hospitals, it's gonna collapse the ICUs, it's gonna collapse the number of ventilators, the EDs, everything. So everyone is gonna be needed. I think this is not the time. I mean, I'm a researcher, but I have to admit that I'm not in the mood of thinking on research now. Maybe in the future, when we come out of this nightmare, we'll turn and try to see some of the experiences that we're having. But we're just in survival mode. That's going to happen, I think, all over the world. And I think you need to really plan, act very quickly, be very aggressive with the measures in terms of planning, in terms of getting facilities, in terms of protecting your personnel, your human work, and in terms to, of course, as physicians, try to get your loved ones locked on. I mean, don't leave your homes. I mean, taking this very seriously. I think there's a consideration that maybe 70 to 80% of people who get infected are from people who are asymptomatic in the first stages. So that's a massive problem, because you think that people are coughing and then you get your mask, but that's completely untrue. I mean, people get infected in the subway, with the doorknobs, with everything in regular life, in shops, everywhere. And when you get realized, because the average incubation time is about 5 to 6 days, it's too late. And that's what I mean, they've seen in Italy. We're just following. We're actually on the rise. And I think the US is already on the rise. So I think you need to do very aggressive moves and to take it very seriously. This is not a minor thing. I think this is the unthinkable and the unseen. I would recommend you to take it. And as I mentioned, this is the time for solidarity. This is the time for generosity. Yeah. I would ask people to really think that this is where everyone is needed. And I have to admit, and I would like to share my impression of how generous the trainees, the fellows, the nurses, my colleagues. I'm overwhelmed as well by the generosity and the big heart that people is putting to save and to alleviate at least the suffering of so many thousand people that are coming every day.
As much fear as there is in terms of uncertainty and how scary it is, I agree with you. The humanity that we've been able to witness throughout of this, through this experience is really special and empowering. If I may ask on a sort of a personal note, what you're describing, I can imagine is physically, mentally, emotionally draining. As a provider, every day you're sort of faced with going back in and just really doing your part, as all providers are around the world. What has your experience been just from a personal standpoint in terms of coping with all of this?
It's a devastating experience. I mean, you can feel that you cannot stop, you cannot help, you cannot even do things that you wish to do. And I'm a researcher, I'm an academic cardiologist. We tend to think that we are a high-level cardiology center, but when you live in this, it's just like being in war. So it's a terrible situation. My wife is also a doctor. She's a geriatrician. Mm-hmm. She's suffering a lot because there's people dying in residencies for the elderly. Like once the virus gets into these residencies, they die like 10, 15 people in a row. And we could see last week, we could hardly sleep. And we didn't speak, but I could realized that she was awakened and I was awakened. So we were exhausted because of the physical experience. We were exhausted of the mental. The weekend was a little bit of relief, and we were taking. But also we have families, children. We are exposed. So we're coming to hospital, get exposed, and we have to come home. So that's very stressing as well. To try it, and if you have something which is vulnerable at your home, you're totally scared of bringing it, and it can be devastating for these patients. So it's a situation in which you, at some point, you think you're gonna become crazy because you still cleaning up everything and yourself, but it's just impossible. It's impossible to control, particularly in the hospital. So I don't know, it's just, I think it's very much about one beliefs and what are your deep roots of what is guiding. I think it's very hard to take it. I think this teamwork, in this generosity and these people working together, taking risks, to save people. Some of them, that there's no option because they will never be intubated because there's no option, is helpful. But you need to get, your family, you get to get some love. But also I have to admit that we are even scared. I'm not touching my children because concern of bringing something from hospital. I mean, you get from hospital, you run to the shower, you get like half an hour getting soap and soap and soap, but you always feel like dirty and infectious. So.
Well, Professor Bueno, thank you so much for being so open and sharing with us your experience, which is absolutely humbling. And I hope that the most that we can do is learn from your experience and really encourage social distancing, just spread the infection, and continue to unite and work together, and hopefully come out of this stronger.